with Jogendra Upadhyay and PANKAJ Patel, both of whom are project directors at Gujarat AIDS Awareness and Prevention Unit, which is more commonly known as GAP, of the International Society for Research on Civilization Diseases and on Environment, GAP ISCRDE. They have been associated with GAP for several years. Jogendra is also Governing Council member of Indian Network of NGOs working on issues of HIV/AIDS, which we call INN. And that was founded by late Dr. Radium Bhattacharya, who unfortunately passed away in 2009. So welcome to both of you. Jogendra, can you share with us how Dr. Bhattacharya helped shape IN and GAP for focusing on people-centric responses to HIV and the impact of those responses?
Dr. Radium is a pioneer person of the field of HIV/AIDS in India. She started GAP organization 1989 for some of the project blood safety and also the sex worker project. And in 1996, GAP started the Healthy Highway project, one of the unique projects of the international level. She was NAC member, National Advisory Committee, in the first phase of NACP1. And she established the Indian network of NGO working on HIV/AIDS and 350 NGO members in the entire country. And every year, GAP, Dr. Radium conduct the national convention for through the Indian network of NGO, and lot of platform like MSM Voice, PLHI Voice, ART Voice, and treatment policy, and lot of policy she developed, and they gave the white paper to the NACO and UNAIDS. In 2005, in India, ART treatment was started, and this is the efforts by Dr. Radium Bhattacharya. See the respect to the community and this theme, the put the people first. You always say, to put the people first for the prevention, control, and treatment, and care and support. And our organizations and lot of NGO activists inspired her, and we started the particularly project in the GAP is the adolescents and children living with HIV. 2009 she passed away from this world, but her ideas, her thoughts, and her work is live. That's all.
Thank you very much. And it's good that she has left behind a legacy of her work and her inspiration also, which continues till today. Can both of you, Pankaj and Jogendra, tell us something about the work you are doing, which you will be presenting at AIDS 2024, and the impact it has had? Any one of you can speak? Yes.
I am sharing the first thing is what we think about the put the people first. Is an important theme for the HIV prevention and care and treatment. We know that we work with HIV And also we work with for human being and humanity. To put humanity being at the forefront, to provide them with the due respect, appropriate services without discrimination to the most of marginalized people. This is our theme about the people, put the people first. This is our thoughts. In India, about 36% people are labor in the unorganized and informal sector, some of whom are migrant. The National AIDS Control Program has a well-planned program of the targeted intervention with the migrant labor. But the program has not reached many of the unorganized and informal sector labor, like a construction labor, small-scale industries, agriculture market labor, fruits and vegetable market labor, sawmill sector labors, and the quarry workers and the small rakdiwala. They are the very big community of in India. They earn the money for the unorganized and informal sector labor. But in the National AIDS Control Program, reach to the only the sector labor, organized sector labor, big industries join, because a lot of people work in this side. But the problem is unorganized and informal sector. Every year they are the change. Every year they are, because of in the and seasonal migration. Like I give the example, the cold storage workers, lot of in Gujarat. In Uttar Gujarat, 10,000 laborers from Eastern UP and Bihar. But they are work at the Gujarat 6 months. Next year, all the labor are changed. And this is the most vulnerability are increased in the lifestyle, and all this so many factors are increase the vulnerability of the STI, HIV, and TB also TB. We focus these people. We support by International Labour Organization and the Gujarat State Aid Control Society under the UBRA project. Our work is a unique because we develop the partnership with the all types of sectors, all types of health sectors, labor sectors, industry sectors, agriculture market sectors, and how to develop our partnership. May I request to the Pankaj, he will explain this all the how to develop our partnership, please.
Yes, over to you, Pankaj. Yes.
Thank you very much. We have agreed 100% agreed with people, put people first. Our ILO project is success. We have agreed with put people first. People first was the primary stakeholders. Our primary stakeholders like DHM, Bharatiya Mazdut Sangh, ISCRDE, Federation of Real Estate Developers Association of India, local builders associations like different districts builder association, local sawmill association, district-wise sawmill association is important for the work. Put people first, and local GIDC association secretary and other association member as important for people first. Also, we have put people first, local contractor, local labor contractor is most important for the successful project. So, in this success labor empowerment project managed by GAP and organized by, supported by International Labor Organization. We have organized locally and state level 15th sensitization meeting for our put people first. Sensitize the people and conducted the meeting and what is our project, what outcome and why it is important. So we have a sensitize the our put people first and all program activity, project outcome, and what service we given labor, all those activity sensitized meeting, the discussion, the sensitization meeting. And they were instrumental and the leading advocacy ensuring we could execute the work and efficiency and effectively we have a work. So put people first is our first stakeholders in our ILO project.
Okay.
Jogendra.
First step of this project, we surveyed of the 1,200 labor for the vulnerability factors of vulnerability, and we find out it 20% this type of labor have a multiple sex partners, and we identify hidden community like a MSM and FSW in this particular the unorganized sector and informal sector labor, because they are not mainstreaming joint in the mainstreaming program of the targeted intervention, but they are hidden people. And we in our survey, the 78% people said that we tested in our workplace. We will test in our workplace. In workplace, we are not go to the centers, health centers and ICTC centers, because we have a no time and cut our money. We go to the ICTC. We are daily wages. The contractor, owner cut our daily wage. Therefore,
we should be at the workplace.
We all the program is done at the workplace. Our second step is because the time is the most factors, because the suitable time for the intervention and community-based HIV screening. We planned all these all these issues. We planned the timetable and time schedule for the intervention and community-based HIV and TB screening programs. In the awareness session, we use the appropriate IC and behavior change communication through flip chart, game, snakes and ladder game, card game. All this we use, because we use this type of the IC and BCC. These are involved by the involved from labor, and also the can easily understand the HIV prevention measures and all these STI prevention measures, what is TB and why the benefits of the HIV testing. We have within 3 years 37,000 labor screened to HIV and TB in workplace through the community-based HIV screening program. Because in India, we know that the self-testing is very far away from our things. But the community-based HIV screening program is the best way to reach the people. And successful result we got because the number of in intervention program. Suppose, for example, 1,000 people are in awareness program, and 80,000 people took a HIV screening in the screening program, and also TB screening program, 4S TB screening program. 87% is a good number for the achievement, because the 87% people are the first timer HIV tested in their life, first timer test, and they are happy. They are happy because they have no spended time for the going to health center and ICTC center. They have no cut the daily wages for this. And in the COVID-19, we gave the some masks and also some things for this for precaution of the COVID-19. In this 37,000 labor screened HIV and TB, in the 116 are new detected of the HIV, and 37 are new detected of the TB. The positivity rate is the 0.31%, is higher than national figure. National figure is 0.23, but this figure is 0.31. Our success story is the 96% new detected case were asymptomatic. Is a very, very successful story. Asymptomatic, because they have no symptoms, they refer to the ART center and registered at the ART centers and start the ART. Because this success story, we can put the people first. We hope that their life is very long and we involve in much more in the labor work. Beyond the HIV, we referred for the government labor welfare schemes like e-Shram card, and also in the Ayushman Bharat card, Abha card. Although we are linked to all these people, though people are happy, and in 116 people, our next step is the index for the index testing, and their family member, spouse and children, and also new detected spouse and children, they are also linked in the ART center. And my concern is this our small project, but India is a large country, and unorganized sector and informal sector is a large community. Therefore, my concern is there is an urgent need to engage with the large group of unorganized sector works who cannot be ignored in if 95, 95, 95 target for the HIV and sustainability development goal have to be realized.
Okay, thanks for sharing this. And you're talking of a very important point of HIV-TB co-infection. So, how do you screen for TB in the people? What is the method you use for screening for TB?
Okay. We have a development a partnership of the local DTO office, district TB office. They are the provide there are three things provided our team. First is the training, TB training, how to forest screening use in the community based screening. We use the forest screening system. If the three symptoms are in the people, we have a for the collect the sputum and give the laboratory primary health center or sub-centers for the TB testing. If the TB detected, they are informers, and we start a dot treatment, and also provide the 500 rupees for the bank
nutrition
account
support.
Nutrition support. And we are the provide the also supplementary nutrition support like a protein powder, vitamin syrup, and hygienic syrup. And we monitor to the for the his finish her dot treatment. And after the finish the dot treatment, we meet with him or her, and also we provide the certificate and all these things because this finish this treatment. This is our TB program.
Okay.
In our cases, one case are MDR TB. We detected MDR TB. MDR TB one labor from one woman labor from cold storage, and also suffering from she was suffering from HIV, MDR TB, and also cervical cancers. And first we started ART. Second is the MDR TB treatment, and we refer to the gynecologist for the cervical cancer treatment. She was very happy for this our efforts, and her son is on his son. We linked with the government scholarship program for the scholarship for the education in the Gujarat state. This is a MDR, and also in this group we specific program for this factory. The specific program with the collaboration with the DTO for the all people are screened all the for the sputum test, and only one person is new detected for the not MDR TB but TB. This is our efforts for the TB program. But here is the in HIV HIV testing, the 96% are asymptomatic, and we refer for the TB testing. They are non-reactive TB, non-reactive STI, non-reactive hepatitis B, non-reactive RPR, and they started ART. Now they are very much healthy. Only we have one challenges because the one person, one labor from the steel factory. His honor said that you are HIV positive and you leave my factory. But we advocacy with the owner, advocacy with the factory managers, and all this thing, our efforts. He joining the factory, and now all the people are very happy for our services because our services is the not only the for testing and not only but one goal because we provide the comprehensive services. We provide all the like a diabetes test, all the sugar test, because you know that sugar the TB patients the necessary for the sugar test. So we also provide the sugar test, also provide the blood pressure test, blood pressures. We also provide the other health issues. We link with the government labor welfare scheme because our program is also comprehensive. That efforts we got the successfully in the index testing for their spouse and their children.
Okay, that is great work you are doing. Just one more thing I wanted to ask. All the people living with HIV, are they being given TPT, TB preventive therapy? Is that being done also or no?
Yes.
Yes,
Pankaj, you say.
Every 6 months, we have a programs with TB test for every youth, male, female, all our children living with HIV. Every 6 months, TB test is compulsory for the government of Gujarat ART center.
No, that is all right. I just means as a lay person, I want to clarify this. TB test is done. Those who do not have active TB, like they may be having latent TB, those people for whom active TB is ruled out, are they being put on TPT or TB preventive therapy? Isoniazid or rifampicin? No, that is not being done because because maybe that will be a good thing to include in your interventions. It means just a suggestion because when the TB test is negative, then they should be given that. And what TB test is being done every 6 months? You say what test do you do on them for TB?
Sputum test.
Sputum microscopy.
Sputum microscopy.
Yeah.
Okay, with one MDR TB patient you had. So how did you know that she had drug-resistant TB? What test was performed for that?
Yes, this MDR TB was in the microscopy sputum test. The district TB officers are doubtful and sputum to the another laboratory in the central laboratory of the Gujarat Commissioner Office is the MDR TB test, and 2-3 types of the test they are done and declared the MDR TB, and all the DTO team are go to the care to the MDR TB patient, and first just they are informed to us, but they are informed to us because this you refer to these patients, he or she is MDR TB, and we now our role is our start from the DTO office, and all the DTO staffs, DTO office staffs, they provide all the precautions and all these things for the MDR TB. But we are not direct involved for the MDR TB treatment. Just we refer to the for the simple TB test. If the detected MDR TB, all the responsibility is from DTO office.
District level.
All right, all right. Thank you for that clarification. Because now, see, WHO has recommended that for TB testing, we should be using molecular tests, and sputum microscopy should be replaced. By 2027, WHO has asked that sputum microscopy should be replaced for diagnosing TB, and it should be replaced with molecular testing. And we have very good molecular tests, even our own indigenous molecular testing platform called TrueNat machine, which can, just because microscopy misses more than 50% of the TB cases. So perhaps you all can also sort of advocate for that or ask for that, that not only for people living with HIV, but others, when the TB test is being done, it should be a molecular test upfront. And molecular test will also detect resistance if the TB is drug resistant or if it is drug sensitive TB. Because that.
In
Yes.
our this program, the 58 we detected TB cases. One is the MDR and 57 is not MDR TB. And also DTO declared that the Nischal program for the support to the TB patient for the nutrition support. And we organized a joint meeting with our stakeholders, like owner of the builders of the construction site, owner of the builder, owner of the factory, owner of the cold storage. On this joint meeting with for the advocacy, with support to the HIV program and support to the Nischil program, and adopt the TB patients for the nutrition care. And we have a success story, because all the we in the our both of 5 districts, our DTO collaboration with the DTO with the district TB office is a very nice and very supportive, and they are the supporters, and we support for the Nischal program for the nutrition support. In our Bal Gopal program, we promise that to the DTO, if our Bal Gopal beneficiaries, the children and adolescents, we have a responsibility. To provide the supplementary nutrition government format program, and also we provide all the hygienic kits and all the raw nutrition like moong, chana, and all these things. So in the last 3 years, we have a 3-4 children, not proper numbers, but 3-4 children. They are also TB and HIV co-infections. We support the full of for the nutrition kits of the beyond HIV and all the kidding. And now they are happy, and also happy to the beneficiaries, and also happy of the DTO office.
Right. So you're working in 5 districts of Gujarat, is it?
In 5 districts.
Yes. So the program, or there is no chance of replicating your good efforts. You had said that earlier also, that there is a lot of unorganized labor sector in the whole country. But even if we take the state of Gujarat, do you think there are chances of replicating your model in other districts of Gujarat?
Yeah, and this is and ILO 2 times International Labour Organization put our work, the best practices in world 2 times put in the International Labour Organization website for the we awarded to the 2 times for the best practices in the for the outreach of the community-based HIV screening and TB screening program. And this is a success story to us. And we think about the replicate the program to necessary for the in few state and few districts of the in Gujarat and in the entire country, like in Odisha, in UP and Bihar, is a necessary for this program, because the large populations are migrant and also from Bihar and Uttar Pradesh and also Odisha. The needs of the because the 6 months they are at the at the home, and this is the this our experience. Not only start at the destination area of the migration, but also started at the resource area of the migrations in our entire country. We apologized, we request to the ILO and NACO, they will start this type of the program, because you know that this group is also left this our national AIDS control program also left, because now if they are the focus on the some industrial zone and metropolitan city, but now is the industry develop and the rural industries have the small town and all these things. Because in the first example, the NCR, the Gautam Budh Nagar district is a very large develop the large industries of small scale industries, and the behavior pattern are not changed, because some environmental issues, some all these things, the risk pattern is or some mostly we identify the hidden high risk group like MSM, TG, and also FSW, because they are not proper sex worker and proper. They are some sex worker with sometimes and work with this unorganized sector sometimes, like just like a catering labor, most probably involve the women, and most risky populations of this unorganized sector labor. And we identify the 0.104 is a positive HIV positive rate in the catering group, but we are not reached in our national program. This is we think about by put the people first, all the respect to the community, and provide the service delivery to the most marginalized and most live in depressed area. This is our theme.
Yes, thank you for that. And Pankaj,
last minute I share.
Yes.
We will attend the 25th International AIDS Conference in Munich, Germany. We have selected in the booth activity. Our booth activity is a Red Panties campaign forum, the smart sex work to young female sex worker. This is our booth, and booth number AD03 in the Global Village area. We have developed lot of IEC, BCC material and education material for the condom negotiation skill and mental health skill, how to develop the mental health skill to the female sex worker. And we have developed the materials, IEC and BCC materials for the exhibition. And my request is all the peoples, you will visit for our booth, and thank you very much.
That is great to tell us something about the booth and request to the people to visit it. Before we end, Pankaj, you have said earlier about putting people first. But as a person on your personal level, Pankaj, what does put people first mean to you? Beyond your project, beyond that, what does it mean to you?
Uh, Dr. A.D.M. Bhattacharya said that if you are successful intervention, your stakeholder is first, and your stakeholder is your first people for the successful intervention program. They have organized in 2004 urban to rural program supported by ISCRDE, and project name is strengthening the Panchayat Raj Institute and how to prevent HIV. So this project, our people first, Sarpanch, relevant service provider like Anganwadi, ASA worker, health worker, parallel Panchayat also our people first. So people first is most important for the successful program.
Okay. Thank you very much. Thank you, Jogendra and Pankaj, for sharing with us the wonderful work you are doing, and congratulations for the impact it is having on society and that sector of society which you, as you said, is left out from so many of our programs. So basically, GAP is filling up that gap which is there.
Yeah.
Thank you.
Yes.
Thank you.
Yeah.
So we were listening to Jogendra Upadhyay and Pankaj Patel of Gujarat AIDS Awareness and Prevention Unit of the International Society for Research on Civilization, Diseases and on the Environment. Thank you, and thank you very much
Thank you.
for being